labels, on the one hand, can be useful. On the other hand, they can actually be making it more difficult to see our child for exactly who our child is. So this is why, in general, when I do talks or speak with patients, or, if I'm at a dinner or so many people ask me questions, or at a summit like this, I try not to have it be the topic of diagnostic labels, because I find them sadly more harmful than helpful, and they're not inviting curiosity and conversation. They invite premature closure of categories, and we then lock onto a linguistic label that then, the way the mind works, we take the label and it creates what are called top-down views. So rather than seeing something fully and freely, we just lock into the label, and then we can't see what's in front of us. So this is why you'll see me take, like the time we've just taken, to say, if you've been given a diagnostic category by a clinician, even if they're a board-certified clinician, you can say, thank you very much. Let's understand deeply what that label really means, and realizing that even if that clinician was accurate in giving you the diagnosis, it doesn't mean your kid is the diagnosis.
Yes.
You know what I mean? It means that they're having symptoms or signs. A sign is something you can detect as a clinician. A symptom is something someone complains about. And that are meeting, I hope it's okay to say, a Chinese menu list of, 2 from here and 3 from there and 4 from there, and therefore you get a label. So a good example would be depression. You can have 2 people meet the diagnostic criteria for depression, and even when you study their brain, it's very different. And if you study things that may have been involved in the etiology, the cause of their depression, the treatment that works will depend on a much deeper set of questions than just meeting the criteria for depression. So we want to be very cautious about labels.
Right.
So that's number one.